Welcome to video 3, the trouble with scans. And I did promise that we get into some philosophy in this video, so here we are. That's Aristotle on the left and Descartes on the right. Aristotle was around about 2,700 years ago, ruminating on all things, including the phenomenon of pain. And Descartes, he was much more recent, about 350 years ago. Now, some of you may have heard of Descartes before. He's the guy who coined the phrase, "I think, therefore I am." Now, both these men put forward a different philosophy about the phenomenon of pain. Aristotle articulated it as a complex, multivariate phenomenon that was intrinsically linked to emotion. Much more up to date than that, Descartes expressed something quite different, that pain was a measurable and scalable response to a fixed signal. If you like, a more mechanistic or direct or mechanical theory about pain. I'm making the argument that this Cartesian philosophy, named after Descartes, is the thing that shaped the prevailing medical culture that we're in right now, and never more so than when it comes to images and scans. The thing that we're told is we're shown, say, an MRI scan of our back, and somebody will point to it and say, "You see that abnormal part or that aberration? That's what's wrong with you. If we change that, we'll change your pain." We now know, however, from more contemporary research that tissue pathology on its own is not enough to explain pain, and that in fact Aristotle was correct. He was more accurate, that pain is a much more multivariate, much more complex phenomenon than a simple, straightforward kind of input-output. So I want to develop this argument that the tissue is not always the issue. And one of the things I think is really important in resolving back pain is not just an awareness of this, but the language that we use. And we hear all sorts of unhelpful things all the time, like, "Oh, you've slipped a disc." Well, they don't slip, okay? They can't go anywhere. "I've got a bad knee. I've got a bad back. You're old. Your discs have degenerated. You've got worn out joint surfaces." This kind of language is not helpful to us because in reality these things may have no bearing whatsoever on pain or function. And it's also the case that if we scanned a random 100 people off the street, we'd see all sorts of variations. Bony outgrowths here, different heights between the vertebrae there. But those people may never be aware of this, and it may not be a limitation to them whatsoever. It's really important to think carefully about the language we use, because words are, after all, what we use to think. So one of the things I'm going to recommend in this video series is that we start to tell ourselves a different story and we don't use self-limiting language or self-limiting beliefs. And again, I like to always present some contemporary science just to reassure you that all this kind of stuff about philosophy and emotions isn't complete woo-woo. So here's a really interesting paper, and in fact the findings are pretty wild. So this is 13 people with a bilateral Achilles tendinopathy. Now, an opathy is the more severe of the tendon complaints. So you may have heard of an itis, a tendinitis. That's your more early stage inflammation, and then if that's left to progress and not heal, it can develop into an opathy, and that's cell death. So the collagen within the tendon has degraded to a point where it's not getting better. And it often goes hand in hand with chronic pain. So in these patients, they've got it in both legs, and they underwent a surgical procedure, but only on one leg, the leg that they self-identified as the worse of the two. And the surgery involved debriding the tendon, which is a fancy way of saying scraping it with a scalpel. Now, after the operation, the researchers followed up with the patients, and incredibly, 11 out of the 13 people experienced recovery from both pain and function in the operated and the non-operated leg. So even the leg that wasn't touched by the surgeon experienced a recovery. And when the researchers looked a little deeper, they found that not only were the subjects not experiencing pain in the non-operated leg, but that at the level of the cell, healing had taken place. So morphological changes, that is the arrangement of the collagen, had improved, and immunohistochemical expression was the same in the non-operated leg as in the operated leg. In other words, the enzymes and inflammatory responses associated with healing had also taken place in the non-operated leg. Now, in the discussion, the authors put forward a couple of hypotheses for this, and what's of interest to us is the pain mechanism. And it would seem that when the body was presented with the right cue, the right environment for healing, it was able to heal the non-operated leg. It was able to produce the correct response, and the change in sensory input to the operated leg had an effect on the pain system in the non-operated leg. What this shows us is the complexity of our body's pain response. And I'd like to make it clear that I'm not advancing the theory that surgical intervention is going to be the thing that cures you. In fact, when it comes to lower back, my personal opinion, not being a doctor, is that you should try to manage it conservatively, that is to say, without a surgical intervention. The purpose of looking at this research is to understand that we can change something elsewhere in the body. We can feed a new afferent input, a new sensation into the body, and then downstream from that, we are able to achieve a cascade of healing effects. This sort of thing is possible, and a straightforward mechanistic explanation, a Cartesian view, if you like, of, okay, I see something wrong, I'm going to poke it or change it or cut it, and then I expect it to get better. That's not 100% of the picture. It's not a sufficient explanation. Don't hang your hat on the image in the scan alone. There's more to this than meets the eye. Thanks for watching.